You know what? I would probably be more when I was at
Amiga. Yeah.
Yeah. Was it? Oh. Yeah. Yeah, it sounds like it. Maybe this will brief bit about it.
You're leaving for the appointment at 1, right? Okay, I'm also leaving at that time. So just remind each other. Yeah. Yeah. Okay, I'll double check that. Yeah.
No. I email Mark Wilsey. Yeah. It's not once in a while, but I read it. And I see the he's tag on like the GIM ICH.
I usually share the slides after.
Oh, I see.
Okay. I think I should know about it. I mean, I know a lot about it, but yeah, okay. Then I can focus on her.
This is probably more really. Yeah. Yeah. Once there's a comment to someone, they're already spending their money. I can deal with you. Like the only reason I can think people going here. That's a big expansion. No, but I remember I did one for my core residency. I went to Collinsville, like an hour and a half drive.
It's strange.
Good morning, everybody. Welcome to Grand Rounds. It's a little easier to find a seat this week than last week, but for those that were here, it's my pleasure to introduce Dr. Hatoon Ezzat, who's the director of the Hemoglobinopathy Clinic here at St. Paul's. And I guess we're going to find out, are we doing enough?
Yeah, thank you, Dr. Casson. Yeah, I look at the attendance this week and oh my God, like last week it was very hard to find a seat. So they had set the stage very high for me. It was an excellent grand rounds actually. Thank you for having me. These are my disclosures. So I'm going to focus over hopefully the 50 or 55 minutes on sickle cell disease. I'll introduce you to the adult program of British Columbia. I'll talk to you about sickle cell disease in general. What are the current indications for hydroxyurea therapy, current indications for transfusion, and then recognize some transfusion risk specific to these patients. And at the end, I'll conclude with talking about some new therapies in sickle cell. So the hemoglobinopathy program of British Columbia, the adult site is here at St. Paul's. It is the provincial program. It has been established in 2009. We take care of around 375 patients currently with different hemoglobinopathy diseases, but majority are thalassemia and sickle cell disease. We do some counseling for the traits, and we do see the other rare inherited red blood cell disorders. Our clinics is a weekly clinic, Tuesday a.m. Majority of our patients will attend the medical short stay for their 3 weekly or 2 weekly blood transfusion. Majority of these are the thalassemia patients. We have a drop-in clinic mainly in the afternoons. Our patients, you will see them kind of everywhere, but majority of the sick emergency room or admitted to 10A or other hospitals. We do have pool of referrals coming from, I guess, from everywhere in British Columbia and other parts of the country if they're moving from family doctors, emergency room. And we've been seeing lots of immigration trends over the past few years as well, so our population has certainly expanded. We do have a referral sheet, and we do really appreciate people referring to us to fill the sheet with the necessary documents. Okay, so before we go on, I want to introduce you to the case of the day. And K-Star is one of our patients, and there are many K-Stars, honestly, out there, I'm pretty sure. So he is right now a 26-year-old male with a more severe type of sickle cell with hemoglobin SS phenotype. He was adopted from Haiti by his Canadian family at the age of 2, transitioned to us from Children's Hospital at the age of 16, with many, actually, unfortunately, complications that included multiple strokes with high transcranial Doppler readings. He was on chronic exchange transfusion, severely alloimmunized, had multiple pain crises in spite of this, multiple admissions with acute chest syndrome, and severe priapism. So before we go on to the case, just touching on the history. So this disease is pretty old disease. It was discovered in the 1900s by Dr. Herrick when a dental student, who's Dr. Noel, used to be admitted to the same hospital where Dr. Herrick worked with what they called as rheumatism. So it looks like he has been having multiple joint pains and hyperbilirubinemia or jaundice. Dr. Herrick decided to look under the smear, and he found these sickle cells, and the disease then was called sickle cell student disease or Herrick syndrome. So this results due to a missense mutation at the hemoglobin level, where there is a replacement at position 6 amino acid, where the glutamine is replaced by valine on the beta globin gene, replacing the nice rounded disc-like red blood cells into a stiff, sticky sickle cell shape that will stick and cause all the plugs in the arteries, veins, and venules, arterioles, reducing the blood flow. It's not only that, these cells will turn on the adhesion molecules like VCAM, P and E selectin, causing more adhesion to white blood cells and platelets too, creating even worse vaso-occlusion crisis. So with this switch from valine to glutamine, the cells became sickle erythrocytes, turning on the inflammation, endothelial dysfunction, and hypercoagulability, resulting in vaso-occlusion, which is responsible in the majority, if not all, of complications of sickle cell, like pain, acute chest, stroke, joint necrosis, splenic sequestration, and multi-organ damage, but at the same time creating hemolysis, which sets the stage for gallstones, priapism, stroke, and other pathophysiology and complications of the disease. This will take the body really apart, making it a multisystemic disease that involves every single organ, unfortunately, in the body, starting from the brain with stroke and microvascular changes, eyes causing retinopathy and blindness, lungs, acute chest syndrome, pulmonary hypertension, which is one of the difficult complications that we try to treat with sickle cell, kidneys, liver and spleen with sequestrations, bones and joints, priapism, and skin lesions. There are many guidelines available for us right now. In 2015, we published the consensus statement of care with for patients with sickle cell in Canada. The UK had updated their guidelines in 2018, and we do have a very nice document, which is evidence-based management of sickle cell disease, published in 2014. So we have lots of guidance. I think it's the application and how to do this. So back to the K-Star case. At the age of 17, K-Star starts to present to the emergency department with severe pain in both extremities that were refractory to home management. He was admitted over the 6 months 10 times with painful crisis. The challenge was he lives not in Vancouver, so it's a peripheral hospital, and it was very hard to manage this kid. And this is a typical presentation for sickle cell. What would you do? Do you admit? How do you assess the pain? How do you manage the pain? So pain crisis is the commonest first symptom of the disease. It occurs very often, it's the leading cause of hospital admission for sickle cell, and it's the most frequent symptom after the age of 2, precipitated by several factors like dehydration, infection, stress, menses, pregnancy, nocturnal hypoxemia like obstructive sleep apnea, and it could affect So it's just the tip of the iceberg when you see the patient actually in emergency room. There's always this stigma that these patients are drug seekers, and there is a tendency to minimize their pain, but actually research has shown the opposite. 54% of these patients will have daily pain on their pain diaries, while their unscheduled healthcare utilization is only 3.5% of pain days. Waiting long time in emergency have been shown to be very instrumental in managing these patients. Actually, sickle cell pain is one of the unique pains that go into prodromal phases. So if you miss the prodromal phase, it means that the patient will have an increase rapidly in symptoms that will lead to admission. And actually, if you miss that, it will be a prolonged admission that could last several days to weeks until they reach the resolving phase. So what we do in the program here, so we ask patients to call the nurse immediately. Once they have the pain, the nurse will talk to the patient and give them the plan for some pain management. The patient will call the nurse back. The nurse will call the patient back for follow-up. If the patient doesn't improve after several hours, not long though, the nurse will be directing the patient to the nearest emergency room. She will be calling the emergency room and sending the pre-printed orders for sickle cell and communicate with the physicians or the nurse there. So these are some tools that we use the program. The one on your left-hand side are the emergency sickle cell wallet cards. We started this initiative a couple of years ago, and luckily it became a national initiative. So every sickler in the country right now has these cards. You could fold them, and they're sort of the size of a credit card. We worked with emergency room at a national level, trying to have the writing in red to be ideally managed within 30 minutes, and please do not transfuse unless it is clinically indicated. I'll talk to you on why that's the reason. We have the contact information, and actually we have physician pager available 24/7 to cover for these patients, as well as diagnose and specific complications. We have the pre-printed orders. They're available on Sunrise, and we try to connect with hospitals to fax them these orders too. You could use them for admission or even emergency room presentation. Some pitfalls of painful crisis. So we have to understand that unfortunately painful crisis is just a clinical diagnosis. There will be no lab that will help you determine that. The patients who have high base hemoglobin might more likely suffer from pain. So look at the hemoglobin level. Ask always the patient, are you in crisis? Is this your sickle cell pain? They pretty much know the kind of pain they're having, and they will tell you, oh, this is different. So it will help you to find what's going on. All races could have sickle cell. It doesn't mean that the patient has a light skin color, he doesn't have sickle cell. And look at the pain diary. It will just help you in the overall management. So how do you treat patients? So it's a stepwise approach, multimodal as well. So do not rely on narcotics only. Use NSAID and other acetaminophen and other methods. Bed rest is very important, oxygen hydration, but do not assess the pain only, assess the patient's mood as well as sleep. Treatment initiation, so it's very important to initiate opioids within the first 30 minutes of presentation, and for this purpose we had this card, so hopefully patient will present it and people will look at it and do what's written there. The preferred modality is patient-controlled analgesia, and this has been studied in smaller population in sickle cell and found to be more effective than giving the intermittent narcotics. You have to assess the pain regularly and treat generously and relieve the patient pain. Admit patient if the pain doesn't go away within 8 hours, or if the patient returns to emergency room less than 48 hours from the time they're discharged home. Or if they have other concomitant complications of sickle cell as infection, acute chest, stroke, or priapism. These are just the admission orders that I showed you earlier. There are therapies that we know of now that they could prevent recurrent sickle cell pain and other complications. This is basically transfusion, which is studied extensively in sickle cell, as well as hydroxyurea, so we'll go into a bit of details there. We call it the magic bullet actually in the program. It does help a lot in these patients. It has several mechanisms of action, but the most important one is induction of fetal hemoglobin, which is the hemoglobin that has the highest affinity to oxygen. But at the same time, it does cause some myelosuppression, hopefully reduce to some extent the neutrophil and platelet number, causing less adhesion of these, as well as reduce the RBC adhesion, decrease hemolysis. And there is more and more literature coming up on induction of nitrous oxide causing more vasodilatation. So hydroxyurea has been studied. It's a very old drug, but has been studied at several levels in sickle cell. The biggest study, though, that we really rely on in our day-to-day management is the multicenter randomized clinical trial that included around 300 patients of the severe type, and hydroxyurea was given to maximum tolerated dose. So basically, you don't stop at a certain dose unless the patient will start to have side effects or toxicity. So you keep on increasing the dose every time you reassess the patient, and it did show quite a reduction in number of vaso-occlusive crises, as well as acute chest syndrome and transfusion. 17 years later, there have been analyses, and it showed that patients who took hydroxyurea less than 5 years had around 87% chances of death. So this would show you how important is this drug. It doesn't improve only the symptoms and complications, but it does improve the morphological appearance when you reach the maximum tolerated dose. So this has been published by Ware et al., where it shows that even the number of sickle cell had diminished with the dose escalation. So hydroxyurea had been recommended on guidelines, and actually right now any infant who is above 9 months of age who had sickle cell disease, regardless of the severity, has to be started on hydroxyurea. So we're doing more and more counseling about hydroxyurea. It does have its own toxicity, the commonest being myelosuppression and elevated liver enzymes, so we have to monitor these patients. We do ask them to do monthly blood tests, but nausea, vomiting, diarrhea, some GI upset, and cutaneous manifestations. Long-term toxicity, which is always the fear of the patient, and it makes the discussion a bit challenging, is leukemia, but there have been no increased risk of leukemia. Teratogenicity is just in mice. We don't have much available data, so we ask patients to stop hydroxyurea if they're embarking on pregnancy. The other challenge with males, it does affect sperm motility, so we have to advocate for sperm banking and freezing before starting hydroxyurea when we cancel the patient. So back to K-Star. So he continues to have pain crisis, refused and became non-compliant to hydroxyurea. He wasn't taking it. He returns with fever, cough, dyspnea 3 days after his pain crisis. He was looking ill, febrile, dyspneic, and his hemoglobin was 90. What is this? How would we treat and approach this? So this is acute chest syndrome, which is the second most common cause of hospital admission in sickle cell. It's the second commonest complication after surgery and anesthesia. It does have a huge mortality in these patients. Mortality could reach up to 25%, and recurrence rate is high. There are risk factors for acute chest syndrome that include high hemoglobin, low hemoglobin F, and steady high white blood cells. The mechanism is huge and complicated, but it's basically vaso-occlusion, some necrosis and infarction of the bone causing fat embolism, plus hypoventilation by the patient, atelectasis, suppression of nitrous oxide. This will get into a very, very vicious circle where there will be a shunt and decreased oxygenation and hypoxia again that will induce further vaso-occlusion crisis. The working definition right now, so any sickler who presents to the emergency room with a lung infiltrate and or any of the below, like chest pain, fever, hypoxia, has to be treated as acute chest syndrome until proven otherwise. Chest X-ray could be normal initially, but what we found that after hydrating the patient, if you repeat the chest X-ray, you could see some consolidation, but it could present anywhere between segmental consolidation to pleural effusion. So treatment is supportive, but the most important thing is to initiate urgent exchange transfusion if the hemoglobin is relatively high, or a simple blood transfusion if the hemoglobin is low, hoping to get their hemoglobin S percentage below 30%, but incentive spirometer, antibiotics if you're suspecting pneumonia, and anticoagulation. Hydroxyurea doesn't help in the acute stage, but it does help with preventing morbidity, mortality, and recurrent disease. So these are based on the guidelines that I've talked to you about. The most important thing is urgent exchange transfusion for these patients. So a few months later, got a call from the community hospital that he had right arm and leg numbness. They were not sure whether he's weak or not. I'm not making these stories up. That's K-Star that he will see at the end of the talk. So what do you do in that case? So first of all, we do transfer patients all the time, so we have a very low threshold, but you have to think about cerebrovascular events in these patients, starting from transient ischemic attack to silent infarcts. But overt stroke is generally secondary to stenosis or occlusion. However, these patients could have hemorrhagic strokes. The hemorrhagic stroke incidence peaks between the age of 15 to 35, but younger than this and older than that, there are more of a risk to have infarctive stroke rather than hemorrhagic stroke. There are again risk factors, so you have to assess your patients for soft features when they come to the clinic always. Like seizures, behavioral changes, academic difficulties, if they had any unexplained loss of consciousness before, and look at their hemoglobin. High steady hemoglobin would put them at a brief risk of infarctive stroke as well. Transcranial Doppler is really helpful, but it helped a lot with children rather than adults. So it measures the peak velocity of blood flow at the middle cerebral artery. It's an ultrasound machine, and it has been found that high velocity is associated with stenosis and vasculopathy. The number is above 200 centimeters per second, and it was associated with around 40% risk of stroke within 3 years. Unfortunately, this has not been validated in adults or patients with different phenotypes other than hemoglobin SS. So again, back to the case, and based on guidelines, treatment is exchange transfusion, and then once they had the first stroke, you have to maintain them actually on monthly exchange transfusion rather than just the one time. The goals of transfusion in sickle cell is really wide, but you want to increase their oxygen carrying capacity, replace the rigid sickle cell with normal cells, reduction in sickle erythropoiesis, and restoration of blood volume. Transfusion in patients with sickle cell has several modalities. It could be just a simple transfusion, which is easy to perform, but patients usually they have very tough, difficult venous access. It does induce iron overload, which is another challenge to manage these patients. We could do manual exchange transfusion, but it isn't time consuming. Usually the nurses would freak out if I say, oh, let's just exchange this patient manually. Iron overload is a risk, but is not as big with simple transfusion. And finally, erythrocytophoresis, which is automated exchange transfusion. It is expensive, but it requires too good venous access. We do not have it, unfortunately, for our sickle cell here at St. Paul, so we do transfer our patient, and we work very closely with the apheresis program at VGH. It doesn't induce much iron overload, but it has other problems like alloimmunization. You have to always consider, am I doing acute versus chronic transfusion? What are the benefits and risk of transfusion? Any alternatives that I could do? What's the baseline hemoglobin? And most of the indications are based on expert opinion and clinical judgment. So back to the stroke and transfusion, there have been lots of evidence behind a transfusion and stroke. Several trials have been done, including STOP 1, 2, SWITCH, and TWITCH. So STOP 1 had changed actually practice in the sickle cell and stroke patients. They've actually included patients with high-risk TCD, that is above the 200, and did randomize patients to either monthly exchange transfusion, minimizing hemoglobin to less than 30% versus just observation. And the study was stopped a bit early because the cohort who had just observation had more strokes than the other arm. So transfusion did reduce the risk of first stroke in children with abnormal TCD. Then the same authors came back and said, okay, now these patients are on chronic blood transfusion. What are we going to do? Are we going to continue this? So STOP 2 trial has been stopped after enrolling only 79 from the planned 100. The reason being the patients who were randomized to just observation versus the continuing transfusion did have 17 either strokes or reverting of high-risk TCD on that arm. So since STOP 2 came, we knew that discontinued transfusion in children with sickle cell who revert to low risk after long-term transfusion is actually associated with high occurrence of either overt stroke or transformation to high-risk TCD. SWITCH trial is a trial that I'm not sure whether it helped a lot, but it posed the question, is transfusion and chelation better than hydroxyurea and phlebotomy or the opposite? And actually transfusion remained the mainstay of treatment because patients who were on hydroxyurea and phlebotomy did probably a bit poorly in comparison. It wasn't a very long trial for follow-up. The TWITCH trial did show, though, that if you carefully select your patient after being on chronic transfusion and switch them to hydroxyurea, this could be a similar outcome. It's a non-inferiority trial. So right now we do select patients very carefully before saying we're okay to take you from exchange transfusion or simple transfusion to hydroxyurea. This remains the biggest challenge in the adult world, honestly. So silent cerebral infarcts, the prevalence is around 40%. So that's really huge. And it's at least twice as frequently in the individuals with sickle cell, more severe phenotype, like the hemoglobin SS and the sickle beta thalassemia. It gets actually worse in the adult population. It is associated with lots of morbidities that unfortunately they're irreversible, like neurocognitive impairment, poor academic performance, neurologic soft signs, but increased risk for overt stroke. The definition has two components. It's an infarct-like lesion on the MRI of the brain, but does not have any neurological signs or symptoms, which makes it really a challenging thing to diagnose. But these lesions are permanent, and they don't really have much for the patient to say, but if you dig for them, you're going to find them. So lots of studies people have been trying to resolve this problem. The biggest study is the SIT trial, the silent infarct transfusion, where they included 196 patients to either monthly transfusions versus observation. The monthly transfusions had 6 between stroke and new infarcts versus 14. So we know that transfusion again wins in this case. It's the question, how would you discover these? Since this came in 2014, we've been trying to screen patients in the clinic, very low threshold to actually MRI them, because we know that the transcranial Doppler won't work in our patient population. So we've done lots of MRIs and maybe MRAs, depending on what we find, trying to identify these patients a bit earlier once they're transitioned. The role of hydroxyurea in the silent cerebral infarct is still to be identified, so RCT definitely is needed. So blood transfusion, as I said, remains the standard of care. You have to do hand-in-hand neuropsychological testing, psychological counseling support, school intervention programs, which our colleagues are doing at Children's Hospital, really doing a fair amount of work on that. Keep an eye on risk factors, which is identified based on the limited literature we have: male, high blood pressure, low baseline hemoglobin, maybe history of seizure, and the Senegal type sickle beta thal. So the recommendations based on the National Heart-Lung Blood Institute for transfusion in sickle cell in general: acute would include acute chest syndrome, stroke, splenic sequestration, hepatic sequestration, intrahepatic cholestasis, aplastic anemia, multi-system organ failure, symptomatic anemia, and before surgery, and chronically for patients with high-risk TCD, previous stroke, and actually the silent infarct were included in the updated UK guidelines as well to be one of the recommendations to transfuse patient chronically. When not to transfuse patient, do not treat a number basically, so asymptomatic anemia, priapism, uncomplicated pain crisis, kidney injury, and recurrent splenic sequestration crisis. Back to K-Star. So I've received a call from his GP, who happened to work as a hospitalist at the hospital he used to visit, and he was admitted with a pain crisis. His baseline hemoglobin was 72, and they decided to transfuse him just given the prolonged and recurrent nature of the pain crisis. He wasn't attending his exchange transfusion just because of the difficulty, because he has to basically fly to Vancouver every time that he's booked for exchange transfusion, A, and B, because he's severely alloimmunized, so we kind of have 2 donors for K-Star in the country. So it ended being really a challenge. His hemoglobin, in spite of giving him the 4 units, was 43. So it was worse, and he was just sure that there's no bleeding. So we brought him by PTN to St. Paul's ICU, and we were wondering, what is this? Is this transfusion related? Is this sickle cell related? What are we going to do with this boy? So it is a transfusion reaction. So I'm not going to talk about transfusion risk in general, but I want to just highlight 2 transfusion risk in these patients, which is alloimmunization and hyperhemolysis. So what actually K-Star had is hyperhemolysis. Unfortunately, there is no consensus definition for that, but it is post-transfusion RBC destruction accompanied by a fall in hemoglobin, which is lower than the hemoglobin pre-transfusion level. And usually it occurs around 5 to 10 days after transfusion. These patients commonly will have recurrence, vaso-occlusion crisis, in spite of you doing your best effort to treat that. They will come with dark urine and onset or worsening of symptoms of anemia. It is almost exclusively unique to sickle cell patients, and it could be life-threatening. We had another patient who was very sick, and actually the hemoglobin dropped to 20 in ICU. And she was about really to die. So it could be life-threatening, and we've seen that in a number of patients. So it is exacerbation of anemia due to the bystander phenomena, where there is destruction of both the autologous and the transfused red blood cells. These patients commonly, instead of that, just the florid hemolysis where the reticulocytes are very high, they will have reticulocytopenia, which is more unique to this complication. That could be positive, could be negative. And there could be, this is the time where there is a new appearance of an allo or an auto antibody, but an antibody is not detectable in around 30% of cases. Risk factors would include transfusion in acute conditions. So that's why you have to think a lot before transfusing these patients. We like always to consult with us if you decide or you had this question whether to transfuse or not. And patients who had a history of delayed hemolytic transfusion reaction could be at risk of hyperhemolysis. Usually it is enhanced even if the blood is compatible. So avoid further transfusion. If you see a hyperhemolysis or suspect hyperhemolysis, do not give further blood. We treated our patients and there is lots of support for IVIG with success. Steroids could be used, but there have been lots of documentation in the literature that steroids on its own could aggravate vaso-occlusive crisis. So try to avoid that if possible. Erythropoietin, the patient who was very sick in ICU, we had to start erythropoietin in her. Eculizumab actually has been reported in the literature, reported by our colleagues at Children's Hospital, and rituximab had been used for recurrent hyperhemolysis syndrome. Alloimmunization, it's a big challenge. Lots of patients are alloimmunized. It could be up to 50% of sickle cell patients who were exposed to blood at one point of their life are alloimmunized. Rate of alloimmunization, though, does increase with the number of transfusions. Majority are anti-Big E, but it could be anti-Big C, K, or any other antibody. This occurs mainly because of the discrepancy between the donor pool and the recipient pool, really. And there are different antigens in Caucasian blood versus the African American blood, where sickle cell is more common in them. Since the start of the prophylactic matching for the Big D, C, and E, as well as the kill antigen, there has been a reduction of the alloimmunization. So every single patient who comes to the program, we have to do an extended phenotype for them just to see what do they have exactly and transfuse them accordingly if needed. Potential consequences of alloimmunization is delayed hemolytic transfusion reaction that occurs in around 11%, O2 antibody formation, and difficulty in finding appropriate donor. So the best approach actually remains to be defined in these patients. So after seeing all this, the only curative treatment remains stem cell transplant. However, it is really limited given donor availability as well as the cost. So we're not transplanting patients at the adult side, but my colleagues at the Children's Hospital, they've been successful in transplanting several patients. So are we doing enough? Honestly, I don't know. It's just a very challenging patient population. We don't have probably enough patients to help us to try to do enough, but we're trying to approach the enough definition. So maybe I didn't mention lots of therapies. It's basically hydroxyurea and transfusion and hydroxyurea. But over the years, universal newborn screening, BC is the first province in the country to start universal newborn screening for sickle cell. Starting of comprehensive care programs, and now we have established the Canadian hemoglobinopathy in 2013 in Canada, identifying centers that could apply comprehensive care for these patients. Penicillin prophylaxis has been shown of effectiveness to protect against infection. As you know, these patients will have O2 splenectomy due to repeated infarctions of their spleen, making them at risk of serious infection and encapsulated organism infection, vaccination, and prevention and treatment of acute complications. With having all this hydroxyurea and transfusion, mortality and survival had improved, very close to 95-100%. However, this remains in children. So this curve, the study is just follow up until 18 years of age. So the burden of mortality is noticeably increasing the shifting to the adult population. So this is another one that is showing that mortality in adult is way worse than children. So we still have to recognize that, with special recognition to the adolescence transition period, because this is the time where several studies has shown increasing death in these patients, more of healthcare utilization by these patients, and there is a tendency to discontinue blood transfusion in these patient population, plus poor compliance and attendance of their appointments. Majority of adults will die or have bad outcome because of irreversible organ damage, plus considerable amount of central nervous system and pulmonary disorder, while kids, if they have a bad mortality or outcome, it is more of an infection rather. So the guidelines available have helped us to identify ways to monitor these patients, hoping to improve their organ function and outcome. So this is just a flow sheet that we do in the clinic, and when we see the patient every time, we have our partners in cardiology, endocrinology, ophthalmology, pulmonology, so lots of other specialty helping us to improve care of these patients. And we do have our regular annual monitoring for these patients if they show up to their clinic appointment. Okay, so what does the future brings? I think I'm very optimistic. There are lots of things happening right now in the sickle cell era. Our site here, we will be starting a trial called the Reset trial, where there is this new molecule called the rivapencil that had shown in phase 2 to improve vaso-occlusive crisis and pain. There are other molecules, and there is gene therapy. So gene therapy had been shown in few patients, mainly from France, to improve sickle cell, and just basically they took from sickle cell disease to sickle cell trait, and they became transfusion independent. So hopefully we will have more reports from gene therapy. I'll talk about two molecules. One is the L-Glutamine, and the mechanism of action is it increase the reduction of the NAD in sickle red blood cells, which will reduce the oxidative stress. It has been approved by FDA in July 2017 to improve the vaso-occlusive acute complications of sickle cell, but it is a quite expensive treatment. This was based on phase 3 RCT, where they gave L-Glutamine. It's an oral medication, which is great, given twice a day. They've tried it for 48 weeks versus placebo in around 250 patients with the severe type sickle cell. It resulted in 25% difference in pain crisis, hospitalization, and reduction in acute chest syndrome with actually minimal side effects. The other one is the crizanlizumab, which is, apparently we love the MAPs in hematology, so one of the MAPs is coming to the sickle cell world. It's an antibody against the adhesion of the molecule P-selectin, where they use two doses, the low dose and the high dose versus placebo, and actually the high dose had shown a difference in the sickle cell related pain crisis in comparison to the placebo group. Adverse events were arthralgias, diarrhea, pruritus, vomiting, and chest pain. So before I conclude, I want to take you back to the K-Star. So K-Star one day came to the clinic with his dad, and he asked his dad to leave, and he said, "Dr. Ezzat, I want to talk to you and Nina." Nina used to be the hemoglobinopathy nurse. I said, "What's up?" I thought it is something serious that he kicked his dad out of the room. So he brought his iPhone, and he showed us a video clip of him actually rapping, like singing. So he said, "I've started this, it's my hobby to write songs and actually sing, but the time I'm spending at the hospital is enormous and I can't do this." So if you want to do one thing, just try hydroxyurea. Take your hydroxyurea every day. So a few years later, actually a couple of years, so I tried all my IT to embed this. It didn't work, so I have to take you to...
They got a hole and bleed like freaks standing wide. We don't love you no more. Everybody's laughing now because they see me no more. Well, let me tell you this, I got two sides of me, and the one you see now got The message in my song is specifically for those who have struggled to live. It's for those who've been abused. It's for those who know what pain is. And we have only one life to live. No matter what your situation is, you are valuable. We all are. I was born in Haiti and adopted at the age of 2 by my Canadian family. I'd also been born with sickle cell anemia, a terminal blood disease. The doctor said I wouldn't make it past 20 years old. Sickle cell anemia is not a great condition to have. It means being sick very easily, physical, weakness, breathing challenges, the list goes on. By the time I was in elementary and high school years, I'd been seriously bullied, hurt deeply, spiritually, mentally, and emotionally. I became quite an introvert for a while, and I started writing my thoughts and experiences down in the form of poetry. I later wrote my first song lyrics at the age of 17. I started to notice that my lyrics were expression of my past. I was born with a terminal illness, but I felt like I needed to be positive about it. By connecting deeply to my emotions lyrically, I was able to write my reality, the hurt, the pain, the threat to my life, and turn it into music. Bleed like freaks, stay away. We don't love you no more. Everybody's laughing now because they see me no more. Well, let me tell you this, I got two sides of me, and the one you see now. Since then, I've found music to be my greatest passion. I want young people to believe in themselves. I want them to reject bullying and oppression in schools. These thoughts all came out in my lyrics, which I later recorded on my debut single, No More. My purpose is to inspire people through my music as a therapy. Remember, no one is an island. You can't do it all alone. Get a mentor or a partner. It's not an easy journey sometimes, but surrounding yourself with great, inspiring people helps, especially those with a common vision. Working with a mentor definitely helps me. Having people around me with a similar story and a passion for positive music has made my life a whole lot more fulfilling than ever before. I'll show you my reminiscence. Ever since I was a kid, nothing went right, cause the haters and the fools would beat me all the time. Getting kicked in, ridiculed all the way through. My mama got scared, she didn't know. My name is K-Star, and you're watching Rebellious. I'ma live the way how the Lord made me. I'ma do what I do, be what I wanna be.
Okay, so that's K-Star. He is off blood transfusion. He's on maximum tolerated dose hydroxyurea, 2,000 milligrams a day. He's taking it every day. He's away from admission for the past 3 years, and we're actually very proud of him.
People are feeling unsafe. Cars are being broken into. Homes are being...
So it is the magic bullet right now, but hopefully the future will bring more to us. So in conclusion, sickle cell disease carries a high mortality morbidity. The benefits of hydroxyurea are well established right now and should be used more actually. Transfusion can be life-saving, but it does have some risk in this patient population, especially. New therapies are emerging and we're hoping for the best. And yeah, this concludes my talk. Thank you so much. Questions?
Maybe you mentioned this, and I'm sorry if I didn't catch it, but do you have a threshold for transfusion?
Again, honestly, we don't look at numbers. It's just everything together. There have been lots of questions about hemoglobin of 40, which is possible, a number that you want to look at, especially if the patient baseline is 70 or 80. I think what's more important is to search why the hemoglobin is very low at this point, more than whether to transfuse or not. Definitely sitting at this number at a longer time is not doesn't carry a good outcome, especially for the heart and the strain. But again, you have to look at everything together.
Right. The STOP trials, is there follow-up in terms of the hyperhemolysis when you're on purpose transfusing versus an acute situation? Do you have any data on that?
Yeah, it's not necessarily from the STOP 1 and STOP 2 trial, but there have been several studies looking at hyperhemolysis happening on patients with exchange or a chronic simple transfusion. And it is always a challenge. And that's why the hydroxyurea in this field has been increased. And probably the Twitch trial had taught us that maybe you want to consider switching. So the way that the Twitch trial is recommending is actually do not switch immediately, but have patients sort of overlapping between transfusion and hydroxyurea for probably a year or so, and then take off the transfusion and see, and do you have to take your patient to the maximum tolerated dose? So certainly it is a challenging situation, and it is well recognized and published in the sickle cell where you have hyperhemolysis resulting from chronic exchange transfusion. Other therapies you should consider, like rituximab, has been with some success in reducing the recurrent events as well.
Can I follow up with the second question? So are we, maybe you mentioned it as I missed it, but within the children population as they transition to adolescence, is hydroxyurea initiated then? Or is this something that we do just in adults?
No, so hydroxyurea, based on the guidelines right now, you have to consider hydroxyurea on any infant above 9 months of age, as long as they have sickle cell, regardless of the severity. We used not to, but still recently when the guidelines have been updated, that's the recommendation by basically every single guideline, Canadian, the National Heart, Blood, Lung Institute, and the UK ones. So.
Dr. Calico.
I'm curious around the transition from pediatrics to adult. At what age does it occur? And what are some challenges and some ideas you have to engage these young people in care? Because I've had a kid who's been at children, and the transition to adults is like a whole other planet. How tender they are with children, and how harsh we, is the relativity?
Yeah, that's an excellent question. And if you have a good answer, just tell me. Shannon will comment on that, but I'm just going to mention something. Dr. Jackson is the director of the bleeding disorder program, and they face the same challenge with transitioning patients. So with the hemoglobinopathy specifically, I have to say our colleagues at the Children's Hospital are doing amazing work, as long as the patient is registered with the program, because there are these patients that are out there and they just show up when they're 18 or 19, and you never know how the management happened. But although Dr. Wu and his colleagues are doing their best, I'm pretty sure we do face a big challenge. These are patients that are growing up. I'm an adult now. They want to take the lead in their health, and they just go non-compliant. They don't come to their appointments. They don't take their medications. They're just out there. So we try our best. So what we've been doing over the past, I would say, 3 to 4 years is children decide on a transitioning patient between, I would say, the age of 16, 18, depending on how ready. They have sort of transition readiness forms that they go through with patients and their families. Okay, this patient is ready for transition. They don't transition immediately. They transfer all their documents. We go, I go with the nurse to meet a children team at Children's Hospital one day. We go over the documents. We talk about the admin stuff to it. And then we attend actually one clinic with them over there. And what we're starting actually this year is we do see the patient fully at Children's Hospital and do our first assessment over there. But we used just to go and attend with them just to know us more. We follow this with what's called a patient night, a transition night, where we have children, their families as well, and we try to get like a role model of the program who has been transitioned over the past 2-3 years to attend that night. We have dinner and some snacks and desserts, and then we take them for a tour to the hospital to show them the different facilities. And then we try the first clinic here, adult, to have either John or Heather attending with us. It has been not very successful just given their busy schedule, but at least when they come first time to the adult world, they have their whole team coming with them. So it worked really well with the thalassemia patients, but the sickle cell, it's kind of just a hit and miss kind of thing. Transition in all chronic disease has been definitely a challenge. I'll have Shannon comment.
Yeah, I was just going to second exactly what you said, but really my point was going to be, I haven't seen K-Star for a few years, and if you asked me, I would have thought he was deceased. And so I just wanted to congratulate you guys. I mean, I think, I sometimes wonder if the population, we have a broad problem with this kind of thing in all of these chronic inherited disease patients, but I always kind of thought, maybe incorrectly, that the sickles, because of the silent infarcts, maybe have more. But he has done something amazing, and he's shown you, and a lot of other patients, that he can do it. He's got the right motivation. So I think that's really a tribute to you guys. That's great.
We just actually had mid-September the annual Canadian Hemoglobinopathy meeting, and we had K-Star coming the night before with his group and rap for the physicians and nurses there. So it was quite cool, actually.
And I think it's back to the engagement.
Yeah.
Figure these guys out. He's a great role model.
Any other comments or questions? If not, before I think there's that next week, endocrinology is going to present on lipids. I read the title, but I won't bore you with it because I'm not sure I understand it. In any case, please come next week. Thank you very much.
Thank you.
Sounds like a hematologist now.
And so, I don't know.
I don't think there are my office. Just years later, I find that. Okay. And I have a 6 shot on your head. Yes.
No.
Yeah, she usually.
She put my name. Anna agrees she was here.
Okay, so you can record it.
Yeah.
Or you can think about it.
She's still reading it about 4 or 5.
Thanks.
But she's not
Okay, see you later.
so she's not taking.
Assuming they'll count that. Hopefully I will count that. Please call me if they don't like it. Alright. Nobody will tell me. Oh yeah. You want me to with me? And you were not here, so I didn't trust anyone else to take it upstairs. So I took it upstairs myself, and then I completely forgot.
Pwede ka na kumuha ng tinapay dyan.
Oh, sure. Yes, absolutely. Want you? Yes. Oh, hi. Thank you.
Yeah.
Yes. Zero on Powell Street.
Yeah. Well, you did a good seat, I guess.
Yeah. That's just a video conference still going on for this purpose.
This we get through stairs at the steps.
Yeah.
So that's cool.
Did you bus over here?
What's that?
Did you take the bus over? Or?
No, I rode my bike.
Oh. It's hard to address this.
I know. But anyway, I was thinking about your murder trial. That's crazy.
Oh, yeah.
Can you imagine like the stuff you see?
Well, it's from 1978.
1978?
I guess.
Really?
Well, the one they were making two discharges. Remains of one of the girls.
God.
Or sorry, 17 years later. Was in jail already. I'm glad.
Seriously, that would have gone on forever.
Well, 51-day trial.
Yeah. And I'm just thinking, like,
that's where to be there.
Well, but that's the thing, though. Like, with cherries and all. Who are those people? Those are people that don't have home cherries.
Oh, yeah.
They don't do that.
Yeah.
I love to be part of the group, but
No, exactly. It would be interesting. One night, listen to pause of 30 after the morning session. I think there was picked in the first or the second group, so we got to go. And everything done yesterday, but people were back today.
oh my god, yes, the whole training.
Yeah. And it's empty. So you're good?
Should I put mine somewhere? do you think?
So, well, we can't use the computer yet.
Okay.
It's still a video.
Oh, well,
It's all right.
Oh, this is nice.
Yeah, getting some tips.
That's right. That's
I can't remember.
The rooms are empty, I gotta be honest.
All the other rooms are? Yeah. They must be on, maybe on.
Then recording, that's your big thing.
Okay, good stuff. I didn't
Could
know.
someone unmute all over the phone and?
I don't know.
Oh, yeah.
You just, I couldn't get the key.
Yeah, it's weird. Kind of part of them. Yeah. Like kind of.
Was it George?
Yeah.
No, I think. Oh, I think maybe it was George. No. I didn't ask.
Sorry, no, that.
Yeah, don't worry.
The people.
Okay.
I was saying, I'm not I don't like public speaking, so I know it's an internal group, but just not my cup of tea.
Remember our presentation at HR school?
And
I felt
well, it's so, I don't know.
like I feel so certain about it.
I know it's not my favorite, but okay, when we can, I'll bring this up.
Yeah, just that'll be good with me.
Pardon?
It'll be good with me. People that are
Yeah. And then we have, I guess, under the agenda, I think we're allowed to do instructions, then I'm first, or after him. And we're supposed to introduce our own groups.
Hello.
Yeah.
Julie.
Okay, what do I have here? This is me.
Yeah.
This is me.
IT is just coming
To work all these things. Good. We'll wait.
And there's still rounds comments, but there's no one in any of the rooms on the screens.
Your call will be disconnected.